Our next panel is on equity implications in health plan benefit design. Equity implications in health plan benefit design. And I think everyone kind of knows the drill we're taking here with regard to self-intros and then moving on to a three-part story. And for this, we're going to go in the order of Mila Kaufman, Mark Friedberg, and Annette James. Mila, can you get us started with your self-intro? Set a good example for Mark and Annette. We'll come back to you for a three-part story. Mila.
All right, sure. Thank you very much. I'm Mila Kaufman, the Executive Director of the DC Health Benefit Exchange Authority. And we are responsible for DC HealthLink, which is the ACA online health insurance marketplace here in DC. And we are focused on addressing health disparities and getting to health equity for approximately 100,000 people that we cover, and that includes more than 5,400 district small businesses and residents. And we've actually implemented equity-based benefit design, starting with type 2 diabetes. So that is why we're on this panel.
Great, thank you very much. Let's go to Mark then.
Hi, I'm Mark Friedberg, Senior Vice President, Performance Measurement and Improvement at Blue Cross Blue Shield of Massachusetts. We're a medium-sized Blue Cross plan. We have about 3 million total members, almost all commercial with some Medicare business. And the reason we're focused as a company on equity, it's actually longstanding. There's two stories here. One is that equity has been a focus of the company for more than a decade. And a lot of that was internally focused on diversifying our senior leadership, our staff, and our board of directors. And we have, for many years, used the Institute of Medicine definition of quality, which incorporates equity within it. In the summer of 2020, for reasons that have been discussed previously, a political window opened up and a policy window opened up to take major strides towards improving the equity of care that our members receive. And for that reason, we elevated equity to be not within the quality pillar of the company, but now being separate. So we went from being a company that focused on a quality, affordable healthcare with an excellent consumer experience to quality, equitable, affordable healthcare with an excellent consumer experience. Thank you.
Thank you very much, Mark. We're going to dig into that a little bit. Let's go over to Annette James.
Hello, thank you so much for inviting me to be on this panel. I am Annette James, a consultant actuary, and I'm representing the American Academy of Actuaries. And this is a nonpartisan organization whose mission it is to serve the public and the U.S. actuarial profession by providing actuarial expertise and advice to public policy decision makers on a wide variety of issues. So the Academy has a long history of addressing public policy issues. And I'm here today because I'm the inaugural chair of the American Academy of Actuaries Health Equity Committee, which was formed in 2020 to provide an actuarial lens on the issue of health equity. So I'm here to share the actuarial perspective and the perspective of the Health Equity Committee as we look at health benefit design.
Thank you very much, Annette. Great to have you, and great to have the actuarial perspective here when you really get down to dollars and cents and is this good ROI and so forth, and are we accounting for it? It's good to have the actuaries so well represented. Well, Mila, let's go back to you. Mila, if you could kind of give us an 8-minute version of how it is that this came to the attention of your organization, the Health Benefit Exchange in DC, what you're doing about it and what you're starting to see. Mila.
Thank you. And first, I just want to big thank you to Mark Fendrick and the whole VB team for all of your help with our equity-based benefit design. We use your team extensively, so thank you. And also just want to say how much we appreciate the work of the Biden administration on social justice and health equity in particular, and the work that the NEIC is doing with Commissioner Arnold's leadership. So just quickly as a way of background, in DC, when we were building our state-based marketplace, we were the last to start our build back in the early days, and we were one of 4 to open our doors on time, October 1st, 2013. And since we've opened, we've cut the uninsured rate in half. We rank number 2 in the nation for the lowest uninsured rate, and more than 96% of our population is covered. So our journey on health equity and addressing health disparities is very similar to the one Commissioner Arnold mentioned. We saw the pandemic data on hospitalization and deaths with our Black and Brown communities disproportionately dying from COVID. And then George Floyd's murder. And so that was a pause moment for us organizationally, for my board and my whole team. And we wanted to do something. We wanted to figure out what we can do. So our board established a social justice working group with a wide range of stakeholders, all of our health plans, our hospitals, our physician groups, experts, consumer advocates were all members of the working group. And the charge was to figure out what's within our jurisdiction. We knew that we're not the ones to fix housing insecurity or food insecurity, or to address other political determinants of health, also sometimes referred to as social determinants of health. So we knew that we were not the place, that's not our jurisdiction. So we wanted to see what we can do. So the working group started to call upon experts to help us understand what institutionalized racism looks like. And we heard earlier about it took decades for us to get to this point. And racism in healthcare is quite complex. And I'll just share some of the things that we've learned. So, for example, bias. A third-year medical students, some of them report that Black skin is thicker than white skin, and Black people have a higher tolerance for pain than white people. Well, that's not true. That is not true, but bias impacts how you treat your patient. And so, and this is a true story, a Black patient ended up in an emergency room and was treated for a drug overdose, as opposed to being treated for a severe episode of sickle cell. Well, that's how bias and racism manifests itself. We learned about clinical algorithms. For example, when you get a kidney function test called GFR, if you're Black, you get an artificially inflated score. Just automatically you get higher points. And that means there's a delay in getting your care because it looks like your kidneys function better than they do. Now, luckily, the clinical guideline entities nationally fixed that race adjustment in the GFR clinical recommendations. But there are lots of clinical algorithms out there that help lead and perpetuate the differences in health outcomes because of the race factor built in. Another example is oximeters, which measure your blood oxygen level. They're calibrated for white skin. And so if you have any kind of pigmentation, you're not going to get an accurate reading. So we learned about all of those things. We also learned about financial barriers to care. And in DC, Hispanics report twice as many Hispanics as white residents report cost as being a major barrier to seeing their doctor. And the same is true for our Black residents compared to white residents. So our working group came up with unanimous recommendations to start tackling these issues that we can have a positive impact on. And those were unanimous, and my board adopted those recommendations in July of 2021. So one important recommendation is to tackle financial barriers to care. And so we did that, or we are in the process of doing that, by changing our benefit design to be equity-based benefit design in our standard plans. And so we have standard plans both for our group market and our individual market. And anyone who enrolls in those plans benefits from equity-based benefit design. And we started with conditions that disproportionately impact communities of color. In DC, we started with type 2 diabetes. And so this January, all of our standard plans cover type 2 diabetes treatment for no cost sharing at all. So essentially no co-payments, no deductibles, no co-insurance at all for type 2 diabetes condition. So that means you get free insulin, free. You get your foot exams, eye exams, lab work, other prescription medication you may need for diabetes, all at no cost to you. So that is in our plan design currently. For next year, we're adding pediatric mental health at reduced cost sharing. So in DC, we are at risk of losing an entire generation of Black and brown children. A lot of it is due to the ongoing impact of the pandemic, the isolation, the vicarious trauma, and other reasons. So we wanted to focus on kids. So next year, we are lowering co-payments to $5. And in our bronze plans, for example, we have $45 co-payments for physicians. So those will go down to $5. And also specialists are included in the $5 copay. Certain medications that children need, as well as some tests. So that is what equity-based design looks like for us now.
Mhm.
We are starting to tackle other conditions that disproportionately impact communities of color in DC, and we'll be adding those to our equity-based design. And I just want to underscore what others have said. Eliminating financial barriers to care is helpful to address one particular problem. This is not the answer to the bias or the reason why some of the wealthiest women in the world, like Serena Williams and Beyonce, almost died during pregnancy. So we need different solutions for all of these problems because the problems are just different. Equity-based design is a critical way to address the issue of financial barriers to care.
Thank you very much, Amelia. You covered a lot of ground. You started in 2013. It sounds like you said that you cut the uninsured rate in half. Your prompts were very practical and noble to everybody. It hit on from the COVID pandemic and the George Floyd murder, prompted you to set up a working group that really kind of bored into institutional racism. And thanks for outlining some of the obvious and sometimes, well, the egregious examples of that. Your board made a set of unanimous recommendations. And among the things you started looking at were equity-based benefit design in diabetes, free insulin, foot, eye exams, and so forth. And then you're kind of turning your attention as well to Black and brown children. And that's going to be like kind of the next wave, it looks like. So you have been busy in the DC Health Benefit Exchange. Thank you very much. Good gosh. Well, Mark Friedberg, let's move on to you at Blue Cross Blue Shield of Massachusetts. We'd like to hear the kind of why, what, and what happened, Mark.
Yeah, sure thing. Thanks, Cliff. And I'd like to thank the conference conveners for inviting me to participate on this panel. It's a real honor to be here with Dr. James and Dr. Kaufman, so thank you. So as I mentioned earlier, we reached, I would say, a new level of organizational investment in the summer of 2020 regarding the equity of care that our members receive. And I would say most of our emphasis so far has been on measurement, and we've invested quite a bit in gathering self-reported race and ethnicity data from our members, and in improving the accuracy, so both the sensitivity, specificity, positive predictive value, all that of imputed race and ethnicity data for our membership, as well as the overall accuracy of what we ultimately care about, which are population level equity calculations, starting with our quality measures, which is the main focus of my department. So we've now transitioned all of our quality measures over to being quality and equity measures. And together with our provider network, Starting in Massachusetts, we've convened technical assistance, information sharing, and for about half of our members who see four of our inaugural large provider networks who are involved in this payment product, we have a new pay for equity contract component that creates for the first time a really explicit financial business case for large provider organizations to make investments in improving the equity of care. So that's been the main area of our focus so far. But as others have mentioned, this is not going to get us all the way. We don't think, we'd love to be wrong about this, but this will probably not get us all the way to perfect equity, which is our goal across anything we can measure. And the next one area of next focus is our benefit design. We are doing, I would say, a lot of analysis around this right now. So the kind of analyses we're most interested in are mediation analyses, where we have variation in benefit design. We have a measured inequity, and we have many of those on our website where anyone can look at those. I'll pop the link in the chat later. And seeing whether benefit design explains some portion of the observed inequities by race and ethnicity, and if so, what that magnitude is. And there's a bunch of reasons why we believe that could be plausible. First, there's been a fair amount written already empirically about the relationship between out-of-pocket costs and equity of care. That can happen for a bunch of reasons. One is that we have lots of different products of varying actuarial value. So the amount of money that members are asked to spend out of pocket varies. Some members might be in higher deductible plans versus lower deductible plans, for example. And if our minoritized members are more likely to be in those higher deductible plans, then that, of course, could be one factor leading to observed inequities in care. Another possibility is that, and I think this really gets to the difference between equality and equity, is that the same exact benefit design could have different effects on different member populations. So let's say we have a $3,000 deductible. We have members in it who are wealthier or less wealthy or have higher or lower incomes. That same exact out-of-pocket exposure might have very different effects on discouraging both necessary and unnecessary care. And we're especially worried about discouraging unintentionally high-value necessary care. So that's where we stand right now. I think, if we were to look back at where we are in 2 more years, I would hope that we have 1 or more interventions in place around our benefit design in a way that's evaluable, so that we can see, what exact benefit we get in terms of measured equity on the targeted conditions, the targeted service we want to increase the use of as a result of those programs. I want to mention one particular limitation to us, and I think this will feed into what Dr. James might talk about, is one of the reasons we have high deductible plans in the first place, and the deductibles and out-of-pocket expenses in general have grown over time, is the increasing cost of overall healthcare. Our accounts, employers by and large, are facing increasing healthcare costs and looking to unload some of that into the workforce. And that's where you get these higher deductible, lower actuarial value health plans. If we're going to be able to, I think, really successfully reverse that trend in possibly a selective way or overall, we're going to need a partnership across the board from many stakeholders on controlling overall costs of care. And I'll just say that if we didn't do that and everything goes into increased premiums, that comes at the expense of wage growth for workers. Thank you.
Well, Mark, thank you very much. And we'll just note for later reference a couple new, we like the phrase pay for equity and mediation analysis. We may ask you to kind of drill down on that a little bit. We appreciate you raising the points about the limitations and high deductible plans in particular, and that's got a problem that's shared by a lot of people. Also really appreciate your focus on measurement, your accuracy. I recognize all your sensitivity, specificity, NPV, PPV, and so forth, and kind of trying to use imputed data to get beyond self-identified data and the kind of methodological and analytical issues those raise. Wow. Well, with that, and we did hear the word actuary already in the air a couple of times, let us move on to Annette James. Annette, you can help us out a lot with the actuarial viewpoint here, but tell us how you got interested, what's going on in your industry, in your profession, and what you're seeing so far. Annette.
Thank you so much, Cliff, and thanks to the VBID group for inviting me to be on this amazing panel. I want to say that the way we got involved in health equity and particularly in health plan design is similar to what Grace Arnold and Mila Kaufman mentioned. In the spring and summer of 2020, the entire country became mesmerized and keenly aware of the social justice issues following the murder of George Floyd. And on top of that, the disparate impact of COVID-19 pandemic, particularly by race and ethnicity, also brought health equity in particular to the forefront of everyone's minds. So the American Academy of Actuaries, in response to these events, established the Health Equity Committee in 2020, so that as health actuaries, we could add our voices to the health equity conversation in a meaningful and appropriate way. So health plan design is just one of the areas that we're looking at with respect to equity. We're also looking at other areas that actuaries are involved in that may be impacted by equity. So we're looking at pricing, provider contracting and network development, population health management, and data and algorithms. One of the previous panelists mentioned algorithms, and I think Mila also did. And so we're looking at all these different areas. We're taking a holistic look at health equity because the health ecosystem is really complex and everything's interconnected. Actuaries are, it was mentioned a couple of times, but we're often in the room working alongside healthcare professionals and decision makers in many areas that may impact equity. So it made sense for us to join the equity conversation. And our approach is a little bit different to what I've heard so far. Our approach is to help develop solutions to health inequity and health disparities by first taking an introspective look at the analytical and actuarial methodology that we often use in our work to see how our traditional practices may be impacting health equity, either positively and negatively. And once we understand that, then we can use our methodologies, which we may tweak based on what we find out in the first part of our investigations to help provide solutions that are impactful. So what are we doing? Well, first of all, I want to start by acknowledging that we need to think about all of the components of benefit design. When we think about health plan benefit design, we usually think of the cost sharing structure, the deductibles, co-pays, co-insurance, maximum out-of-pocket limits, and so on. But there's so much more to it. In addition to the cost sharing structure, benefit design also includes the services and benefits covered by the health plans, the extent to which these services are standardized, which I believe a couple people have already mentioned. And it includes which providers will provide covered services in network and which are out of network, and also the cultural competency of the providers. The benefit design also includes utilization management controls, such as pre-certification, prior authorization, continued stay review protocols, and so on, which are used to manage access to covered services and to control costs. And as was mentioned earlier, we want to make sure that these protocols do not actually discourage required care. The prescription drug formulary, which is the list of approved prescription medications and pharmaceutical products for health benefit plans, is also an important part of the health plan benefit design. So I just wanted to kind of make sure that we were talking about the whole universe of health plan benefit design. The Health Equity Committee set out to explore whether there are actuarial, as I said before, actuarial practices or methods that we use currently when designing benefit plans that may affect disparities. So we're working on several fronts here. Data is essential to the work that actuaries do. It's essential to looking at health disparities. So we're looking at data collection methodologies and the measurement of health disparities, because it's a fact that you can't change that which you don't measure. So we want to make sure that the way we measure health disparities is appropriate, and that the data that we use, we understand the data that we use, so that we're not embedding biases into that. One of the things I wanted to mention here is we've identified that historically marginalized populations tend to underutilize healthcare services. And it's important to understand why that is, so that we can develop solutions that do not perpetuate or exacerbate health disparities and health inequity. So, for example, just to be specific, if the data that we're using to project costs and so on into the future reflects the underlying bias of underutilization by historically marginalized populations, then whatever we do the results may also be biased. So for some purposes, it may be important to understand the biases and to adjust our data to avoid unintended consequences. And we've seen that play out in the population health management arena. And so that is one of the things that we're looking at. We're also currently working on, in the very initial stages of looking at research related to the effectiveness of non-traditional benefits. And so the first benefit that we're starting with is transportation. And there are different approaches to providing transportation benefits. So we're interested in understanding the different approaches and the effectiveness of each of those approaches. So we also understand that health inequity is not a new concept. Policymakers, researchers, a lot of people have been working on solutions for decades. And innovations such as value-based insurance design have been around for years, but they've not gotten any traction. So one of the things that we are currently working on actively is planning a series of workshops that will tackle the barriers. We understand the solutions, we understand some of these innovative solutions, but we want to focus on why they haven't moved on and tackle those barriers to implementation of these innovations, and hopefully come up with practical ways to overcome these barriers. So, for example, we've heard many, many reasons why, VBID, for example, has not gone mainstream. And they range from convincing the C-suite that this is a good investment. So we heard about this mentioned earlier that we need to talk about ROI. So the question is, are we looking at ROI, return on investment, correctly? Is there a way for us to think about it differently? Should we use the social adjustment? Should we look at a different time frame? Those are the kinds of questions that we want to address in the workshops that we're having, and so that we focus on the problems, we try to find solutions, and then provide those solutions or suggestions to a broader audience, so that everyone can take something from what we're learning. Another one of the issues that we've heard is our systems can't accommodate these types of designs. So, we are, as I said, in the midst of planning a series of workshops to identify and discuss the barriers to implementation of these innovative designs that can help equity and find solutions to the major obstacles. We're also planning, as a result of this series of workshops, we're planning on having a health equity symposium in November that will bring together all the findings of the workshop so we can tackle it head on and hopefully move the needle forward. So I know we have many different perspectives here on this panel, and I invite you guys to reach out to me if you're interested in joining us on these workshops and the Health Equity Symposium, because one thing that I've learned is that collaboration is essential. We can't, each of us has a slice of the pie. We have a small view of what the problem is, and we can't solve it unless we work together. So our goals essentially regarding health equity, to close, is our goal is to use our actuarial expertise to work towards solutions that would decrease health disparities and health inequity. And so, as I said, we're looking at many facets of disparities, and we're looking at it from a holistic kind of holistic perspective, and we're well aware that we don't know everything about health equity. So we're looking to collaborate.
Well, thank you, Annette James. Gosh, you packed a lot into that, and just it seems like your professional society got into this fairly recently, but it's doing so much very quickly. I can't help but notice that your public awareness of this came from COVID and the George Floyd murder. You respond with a health equity committee looking at health plan design, pricing, networks, and algorithms. You pointed out that plan design isn't just one or two things. It's a lot of things: services, benefits, provider networks, cultural competence, care protocols. Wow. You emphasize data collection and measurement methods. And are we measuring it correctly? This sounds a little bit like Mark and another speaker before that. You really pointed out how marginalized populations are underutilizers. What a very important point, and that can build in a bias in the data. If they're underutilizers and you don't realize that they're underutilizing, that's going to bias any programmatic initiatives that could flow from that. Thank you very much for getting into next, I think, non-traditional benefits. You talk about transportation. I know one of our questioners raised earlier about food security, housing security, and transportation. You're setting up another set of workshops, and you ask us and yourselves to think differently about ROI. What really goes into the R for return in ROI? So, wow. Thank you very much. Okay, we got a bunch of questions here. Mila, the first one's for you, and kind of, I'd say like you're almost asking for this one, which was, how are you making it work with that free insulin and all those great services for diabetes? Like, who's funding that? How are you kind of covering the cost of that, Mila?
Thanks for that question. So, well, first of all, I'll start off by saying everyone benefits from the new plan design. So it's not just communities of color. It's if you have been diagnosed with type 2 diabetes, you benefit. So everyone benefits. How's it being paid for? So there are two separate issues. One, is there an impact in rates? That's really the first question. And for us, the answer is no. Our rates were filed last May for a coverage that started in January, and there was no adjustment upwards for type 2 diabetes care and services covered at no cost to the patient. So it had no impact in premiums. Our big challenge was, how do we make it work for the actual value calculator that all of our metal levels have to fit within? So that was quite a challenge. We had to, unfortunately, raise for a couple of our metal levels the maximum out-of-pocket cost protection that exists. We hated doing that, but that was the only way we could fit within the ADC. And this is one area where we can use a whole lot of help from the Biden administration. We've said this in our comments to them, that really more flexibility around the calculator itself to give actuaries and our health plans more flexibility when it comes to equity-based design, or ensuring that everyone has primary care, or the other public policy goals that many of us have outlined. We need additional flexibility. Otherwise, the ABC itself, the calculator, becomes the barrier to us.
Good point. Thank you very much. Before I forget, Annette, several people are asking, how do I find out and sign up for these workshops? Is that something they go to the website, or how do they do that? You can either address it offline or tell us quickly.
Yes, wow, that's great that people are interested. I'll give you an email address. It's Williams, WILLIAMS @actuary.org. And that is the email address of the health policy analyst at the American Academy of Actuaries.
Thank you very much. Okay.
Yes.
We may put that in the chat as well.
Yes.
I have another question for you in a little bit, but over to Mark next. Mark, ERISA, any adjustments needed to be made in ERISA to account for this?
I don't know.
Okay, well then you'll put that in your inbox then. Somebody did ask about that, if we have to make adjustments. The next question also for you.
I'm happy to answer as a
Sure. And that, Mila, go ahead, Mila.
as a recovering ERISA lawyer, former federal regulator. The answer is yes. So I'm so glad you asked that question. Absolutely. Whatever we do at the state level, whether it's the state-based marketplace or the insurance department, it essentially, for the most part, does not apply to self-funded ERISA plans, period. And so if we want to impact our population, all of our residents, we absolutely need some flexibility or a stronger partnership with the U.S. Department of Labor to help implement some of these initiatives more globally, instead of just applying them to a portion of our population. We're just preempted by ERISA from requiring ERISA self-funded plans, from including some of these new benefit structures.
Well, I'm glad you came up with that answer. Very good. That was like the right answer. ERISA is some more work needs to be done there. Mark, a follow-up question to you. Actually, it's asking about any policies or imputations that you might do for Asian American or Native Hawaiian or other Pacific Islander individuals. I know all of us have mentioned about Black and brown populations, but what about these populations as well, Mark?
Yeah, that's a great question. So there's two answers. The first is there's a slide deck I'll make available that we presented at the National Quality Forum in January around the latest research we've done on imputation methods. And right now we're using a hybrid approach, some gold standard self-reported by our members, at a minimum using FIRE Level 1, also known as the Office of Management and Budget 1997 Race and Ethnicity Data Standards. That's 5 categories of race, 2 for ethnicity. People are probably quite familiar with this from the US Census and pretty much any federal form. Within that, there's an Asian category, and also the Pacific Islander and Hawaiian category mentioned by the question. We do not have sufficient numbers of that latter population in our membership so far, especially having given us self-reported data that we're able to evaluate the accuracy of imputation for that specific category. But for Asian, we can. And there, we're over, I think, 90% specific and sensitive with the imputation methods that we're currently using. That's in the deck that I can share. In the future, in the near future, actually, we're moving to much more granular race and ethnicity data collection, moving to what's called FIRE Level 2, that's FHIR, that stands for Fast Healthcare interoperability resources. This is a federally mandated data standard for race and ethnicity and many other things for the purpose of interoperability and information blocking regulations. So it affects both payers and providers. There, for example, you move from one category of Asian to, I think, 14 categories of Asian that get much more precise, and we'll be offering that to our members as well. To my knowledge, there's no imputation method currently in existence that gets to that level of specificity. It's at those higher levels of aggregation so far.
So Mark, another follow-up, if you don't mind, because you raised it. Where are we now with the state of the art of getting from self-identification through imputation to greater accuracy? Are we kind of at a flat point in the curve, or we still have somewhere to go to pick up accuracy?
Oh, I think there's an enormous potential to pick up more accuracy. For a health plan, the bare minimum you can do is use imputation based on name and geographic location of your members, and that's a freely downloadable algorithm from the RAND Corporation. That's been around for a while, but it got a big upgrade last year. It's a good starting point, but you can supplement that with data from providers, data from government, like immunization registries, and none of these external data sources are perfect, but they're still incredibly useful. And those can be fed into a statistical model to improve on the back end by a large amount the accuracy of the imputation method. But you can't do any of this work to move beyond the RAND algorithm without having a substantial amount of self-reported gold standard data you collected yourself.
Well, Mark, if you don't mind, after this session, can you put into the chat box the hookup to the RAND report, if you don't mind?
Sure.
Okay, just 4 minutes left. Annette, a question for you. Can you dig a little deeper into the non-traditional benefits stuff, the housing, food insecurity, transportation? I know you kind of embark on, but can you say a little bit more about your thinking on that, on those?
Yeah, so what we're looking at, there have been some non-traditional benefits piloted or in the Medicaid and Medicare space. And so the question is, how can we move that into the commercial insurance space? And so what we're looking at, and we're just getting started on that, and so I don't have very much information on it right now, but what we're looking at is really looking at these benefits and seeing how effective they are, and are there different versions of these benefits that are more effective than others? So are there different ways, for example, if we look at just transportation, are there different effectiveness levels of different types of transportation benefits? So if it's by contracting with, say, Uber and Lyft, as opposed to having greater access to the traditional ways of providing transportation benefits. So are there different effectiveness levels depending on how you address that problem and the type of way that you approach the having those benefits?
Okay. Question for VBID staff. We've had a few requests for our panelists' contact information. I don't know if we want to kind of get into who can do that now or later, but we need to be able to say how our listeners, how our participants can get in touch with our panelists. Back to the data question, here's another one for you about getting at the data. And I want to actually start with Mila on this one, but have the other two answers as well. What about tracking LGBTQIA+ populations? How good are we at doing that? It seems like when we talk about data, there are some gaps along those lines. More interested in that. What do you have for LGBTQIA data? Mila.
Yeah. So when I talk about communities of color, what I really mean is communities of color and all other marginalized and vulnerable populations that have been excluded or pushed out or not given the same level of care as white Americans have. And that includes the LGBTQI+ community. On the data question, it has been a huge struggle for us. So we get about on our individual market, about 70% of our applicants for health insurance provide us with their race ethnicity data, and they can pick all the
Yeah.
categories that apply to them. But so the other 30% don't, and we do not ask the question on self-reported LGBTQ status.
Okay,
We are changing our application to make gender identity essentially, you can choose both genders, you can choose neither. Right now, we force you into one, and we recognize that in itself actually is very demoralizing to some populations that we serve. So we are changing that. We are working with all of our health plans on better data collection, and we agree with Mark. Self-reported data is really the best source, but certainly we appreciate that our health plans are using other data sources to get a handle on all data, including language preference and other important data that will help our health plans understand how their populations are doing and where they need to intentionally focus their interventions to get to health equity.
great. Thanks very much. Mark, you have 30 seconds on LGBTQIA. Mark?
Yeah, I'll just say it's an area that we're moving into. We're not limiting our efforts to inequities on the basis of race and ethnicity. I'll just point out, it's not in the question, but sometimes you hear the acronym SOGI, sexual orientation,
Yeah.
gender identity, as if it's one thing implicitly, but from a data standpoint, gender identity is much more complicated than sexual orientation, mainly because gender identity figures all over the place in health plan data systems, from the risk adjustment models to the quality measures, NCQA quality measures. Many of them only currently accept male or female. So a ton of stuff has to change for us to fully ingest other gender identities. Thanks.
Excellent. Thanks very much, Mark. Well, out of time, quick announcement. For these panelists and any panelists today, if you want contact information, please email the VBID Center. So that's vbidcenter@umich.edu and ask for panelist contact info. And to the extent it's available, we'll share that with you. Wow, what a session. You wouldn't believe how the list of questions that we couldn't get to. There's just so much interest in all three of you. So greatest of thanks to Mila Kaufman, Mark Friedberg, and Annette James. Wow, you just pumped us with a lot of data and methods and great considerations. Great appreciation for all three of you. Thank you very much.